Now, on Wednesday, nurses have renal and genitourinary nursing exams. We are going to cover what is supposed to be contained in the exams. Always remember, the exams are readily available on the portal. I'll give you a short clip after this. Now you can access them. Now, this is still the standing page. Now we'll check on the renal and genitourinary nursing. Okay, now this is renal and genitourinary diseases by Ven Kemuma. First and foremost, one thing that I'm sure that nobody can forget is the structure and the anatomy of kidney, how it looks like, and the morphology, externally and internal morphology in terms of the parts compounding the kidney itself. So we have the right and left kidney. Yeah, actually they're located on the same that is peritoneal cavity next to the abdominal cavity. But again, the kidneys are not level. One which is the right side of the liver is a bit lower than the left side. That is to create the space covered by the liver. We have the internal part of the kidney, that is the medulla cavity, the cortex, and the calyx and the hilus and the pelvis of the kidney. Those are the internal. And all these ones, they actually have nephrons, okay? And they are the basement functional of the kidney. Now, and then the external, we have the capsule which actually cover and protect the kidney, and then the renal papilla. So, functional anatomy of the kidney, it is simple. The kidney normally helps in urine formation, and that is what you've been learning. You remember in biology in Form 2, that is excretion and homeostasis. The functions of kidney, we had filtering waste product from the blood, balancing the blood volume, regulating the pH of the blood. And the pH is that the acidity and the alkalinity of the blood. There are also some hormonal function of the kidney, secretion of some hormones like erythropoietin, which is responsible for production of the erythrocytes, the red blood cells. We have some hormones like renin, which is important in regulation of blood volumes and therefore blood pressure as well. It is a compound in the system which is called RAS, renin and angiotensin aldosterone system. So in the kidney, other organs which compound the renal system is kidney, we have ureter, we have urinary bladder, and then we have the urethra. Now, the functional anatomy, first of all, you need to know that inside the kidney we have a part called nephron. And the nephron has got many other parts, okay? The nephron is very small. You cannot easily see it in the naked eyes. But one kidney will have about 1.3 million nephrons. So parts of the nephrons include the afferent and the efferent arteries. Those are the ones which actually get the blood from the renal artery and breaks it into the arterioles and the arteries, now, which now bath the nephrons. And they're the ones which take the blood which is supposed to be filtered into the nephron. So the nephron, once the blood are inside the glomerular complex, ascending and the descending tubules will do the filtration, the loop of Henle, and then the collecting tubes will now collect the urine, and they'll be having the urine. So I'm sure that the physiological function of all these nephron, in terms of all these parts, you guys are well articulated with, because if you're not, then you should go and check on that. So the way I just have told you, we have capillaries which bathe the Bowman's capsules. Yeah, I don't know if you have an image just that I can. So this is the Bowman capsule here. So these arteries, they enter and they bathe these Bowman capsules, and they will have what we call ultrafiltration of compounds. Okay, proteins and red cells are large, so they cannot pass through the Bowman capsule. So the remaining one, beta amino acid, the vitamins, the glucose, the urea, the creatinine, they are going to be filtered and they will go to proximal convoluted tubule, this part here. So that is the beginning of the tubes. And then from here, we have what's supposed to be taken back to the blood, like glucose, excess water, some water, amount of water. And then the urine flows to the descending limb or the descending loop of Henle, and then to the ascending loop of Henle. Remember, loop of Henle is a name of somebody who invented this. So you, when you're writing it, remember to capitalize the name. So then it comes up to the distal convoluted tube, and then it goes to the collecting duct. Here is where now we have the urine. So the entire statement is the same what this guy is saying here. Okay, so the capillary are supplied afferent arterioles and drain to the efferent arterioles. And then you have two cell layers separate blood in the capillaries and the filtrate in the Bowman's capsules. And these layers are separated by basal lamina. So in the basal lamina, we have things to do with the stellate cell, or you can call it the mesangial cells. They are located between basal lamina and the endothelium of the Bowman's capsule. So they are located in this region here. If you can see, let me try to zoom this region. We have basal lamina here, and then we have mesangial cells. Okay, so yeah. So the stellate cell or mesangial cells, they are located and these cells are contractile. So its role is to regulate the glomerular filtration. Glomerular filtration is the filtrate, the process of filtering the urine, which happens in the nephron, kidney, the Bowman capsules. Because I told the blood is filtered, and what is the filtrate now moves into the tubule. They collectively form the urine. So that is glomerular filtration. And this rate is going to determine for us several conditions. If we have low glomerular filtration rate, that is to mean somebody goes to pee or maybe goes and pass urine very scarcely in a day, maybe once in a day, or maybe doesn't completely. So those are indicative of some condition, medical condition. So the mesangial cells also secrete immune complex and production of glomerular diseases. They prevent conditions that can come because they have immune response to them. So functions of the kidneys. I've talked about water and electrolyte balance, body fluids, osmolarity and electrolyte concentration, acid-base balance, that is the pH balance, excretion of metabolic waste, regulation of arterial pressure, and secretion of hormones. I'm sure that you understand we have erythropoietin, I've told you, renin, and 125 dihydrochlorocalciferol, which is important in vitamin D synthesis and production, which is the vitamin D is also important in the bone formation. So erythropoietin for red blood cell production, renin for blood volume regulation and pressure, and then cholecalciferol is for vitamin D, which is for bone formation. So this is the nephron itself, and I've already discussed that. So the nephron and the urine formation, you see from the glomerulars, it gets into glomerular capsules. Of course, the blood from the heart comes in with the renal artery into the glomerular capsules. And then on the condition that is due to the pressure gradient, which differ from inside and outside, there will be filtration of, we call it ultrafiltration, and it is very selective. So you can also call it selective ultrafiltration. And then the blood gets into the filters get into proximal convoluted tube, which is the filters just mainly water, glucose, amino acid, vitamins, mineral salts, yeah, and then some even drug compounds which are supposed to be extracted. If you are on some drugs which are actually renally, they are secreted in the renal. They use kidneys to force excretion. Then you'll find them also as a component of this filtrate. So then the tubular reabsorption takes place. Water is taken place by the active diffusion, and glucose, which is important by active transport. That's why they are always having mitochondria on the membrane, and also that is why it is coiled. The loop of Henle does its work, and then we'll get blood into, the urine component into this distal convoluted tubule, then into collecting duct, and then excreted. Sphincter muscles on the bladder. Now, because you know that the renal system has the bladder, it has the ureter, it has the kidneys, it has the urethra. Okay, so on the bladder, muscles, which controls how you go and pee, how you urinate. So the sphincter muscles on the bladder. So the internal urethral sphincter, the smooth muscle, the involuntary control, the more superior located. So the internal urethral sphincter is purely a smooth muscle, and it controls the involuntary passing of urine. That is involuntary opening and closing of the bladder. Involuntary is unconsciously, without your consciousness. So when you're peeing, there's some stimulation on the nerve which control the smooth muscle in the internal urethral sphincter. Therefore, it automatically opens up. That is the involuntary control. So it is superiorly located. So it's located almost within the bladder, the neck of the bladder towards in upper part. Then external urethral sphincter is a skeletal muscle, so it's not a smooth muscle. It is voluntary control. So you control it by your own conscious, like you can contract it. So when you have, you are full of urine, your bladder is full, you will feel to go and pass urine. So there's some mechanism like you will exert thoracic pressure, and then there's some other following cascade of mechanism that now will elicit it for the, external urethral sphincter to open up. So it is voluntary, it is intentional, okay? This is now posterior located. So the urethra, which drains urine out of the bladder, the male urethra is 20 centimeter, that is very long. Then the female is around 3 to 4 centimeter, very short. So short length is, there's always a reason. There's other MCQ which will ask you why is female prone to STI than male. It's because of the short length of the urethra. So it's why female have more urinary tract infection than males. So ascending bacteria from stool, ukijipanguza, when you are cleaning yourself after passing stool, when you contaminate your vagina, or maybe during sex activity, when you contaminate your vagina, the shortness of the urethra make the bacteria to ascend faster into the blood, and therefore you'll get infection. So this is how it looks like. If you can see, this is how it looks like. So this is how it, we have the urethra, so from here going out, just in the females from here to here only. Yes, now this is how it still look like, and this region is called the trigon in the bladder. The trigon is prone to infection. You can be asking MCQ, why is trigon prone to infection? Because it is never becoming wet. This urethra, they pour urine to this region. Then the bladder, the urethra, gets it out to the penis or through the vagina. And now this trigon region is more of like a triangle, right? And the triangle will never be dry because when the bladder is emptied, these ones still bring in urine. So this place can be empty by here. So infection, bacteria can harbor easily, they can breed. It's just like a culture zone. So that is what is always prone for recurring infection. So people who present with condition of bladder, maybe cystitis or just bladder infection, this is the region that is prone to the recurrence of the infection. So you see, urethra is divided into three actually in male. We have membranous urethra, okay? We have the spongy urethra, okay? And external, no, it's always membranous. There's another one here, but it's not included. We have membranous, we have spongy urethra, and then there's another one somewhere at the basement here. Okay, you go and check the third one. Now, investigative procedure. When somebody comes with the conditions which revolves the renal region, there are several as well. Conditions of kidney, condition of nephron, condition of urethras, all those organs which associate with or compound the renal and genitourinary system, they can be infected, they can be having condition or disorders. So what we do is to investigate, okay? Remember, acute glomerulonephritis, we have nephrotic syndrome, those are still conditions. We have cystitis, we have urethritis, we have prostatitis. Those are infection, and some of them are manifesting in inflammatory, with inflammatory. So investigative procedures. Sometimes we do intravenous urography, right? Intravenous pyelography. We can do urethrography, cystogram, cystoscopy. We can use urine analysis. You call it urinalysis. It's faster. Some people pronounce it for urine analysis. So it's supposed to be urine analysis. But even if you write U stroke A and you request for lab on the same, it's okay. If you can just say urinalysis, and that is okay as well. Then we have renal biopsy and scan, renal function test as well. So intravenous urography, the kidneys do not show up well on ordinary X-ray of the abdomen. So when you're doing intravenous urography, intravenous means something is applied to the vein, okay? So when you take an X-ray of the abdomen, you won't see the kidney well. So for you to have the clarity of the kidney, so you do intravenous urography. These are tests that we still use X-ray, but now we have a dye. The dye is like a stain. So it helps us to assess the kidneys, ureter and blood and the urethra. So that contrast dye is injected into a vein and the dye travels in the bloodstream. So it concentrates in the kidneys and it's passed out in the ureters with urine. And therefore, yeah, because it moves from the blood into the kidney. Now, when you take X-ray, you will see any condition because that dye will have stained the path and the tract inside the kidney. So there is a greater detail of the structure because you'll see the dye, how it flows, and it will map and give some stain. It's like just a staining technique. So the image, you will see this is where the ureter is because the dye is visible. So it is also possible to assess roughly how well each kidney is working by that. So intravenous urography. And then you have urethrography. Mostly it's done to male. This urethrography procedure is done to male patient. So radiographic study of the urethra using iodinated contrast, still a dye, yeah, is generally carried out in males. They are studies. So uretrogram is usually carried out to show the cause of poor urine flow. People who have urine dribbling, urine incontinence, urine retention. Okay, so when you do your uretrogram, the uretrogram is to show how poor or what caused the poor urine flow. Okay, it can be run if you want to check a stricture, that is narrowing of the urethra. And the most common cause of narrowing of the urethra, is the enlargement of the prostatic gland, or we call the BPH. Okay, benign prostatic hyperplasia. So cystography is a diagnostic procedure that uses X-ray to examine the urinary bladder. Cyst, anything cyst, talk about bladder. Cystitis, inflammation of bladder. So these medical terms, they're easy to integrate, but it still requires some ideally measured perspective. So contrast dye is injected into the bladder. So it may indicate how well the bladder empties during urination and whether any urine backs up in the kidney. So cystoscopy and cystogram, two different. Cystography is a diagnostic process that uses X-ray to examine the urinary blood. While cystoscopy, the word scopy, now is like a telescope. So cystoscopy is a procedure you want to see inside the bladder. So you pass a telescope like gadget through the urethra, and the cystoscope is a gadget. Okay, it's a long thin with an eyepiece on the external end and a tiny lens and a light on the end that is inserted into the bladder. So the small lens magnifies the inner lining of the urethra and the bladder, allowing clear visualization. So when you talk about urinalysis, and urinal is very useful test in the diagnosis of and screening of many diseases and conditions. And it results of a urinalysis may be helpful in diagnosing things to do with the urinary tract infection, yeah, UTIs. Okay, you talk about UTIs. I'm talking about UTIs. I don't want to go into detail because in medical, if I want to detail all these things, I won't even finish today. So kidney disease, you can also check it by doing U and A, that is urinalysis. Diabetes as well, we do urinalysis. So in diabetes, we do urinalysis to check on the ketones in the blood, okay, or glucose in the blood. Ketones in the blood, we call it ketonuria. Glucose in the blood, we call it glucosuria. So, all kidney diseases also can do urinalysis. Okay, yeah, when you have glomerulonephritis, we expect to see blood in the urine. So, urinalysis is something very typically, mostly it's carried by lab techs, but even clinical officer who went through the training well can handle this because they did what we call the medical parasitology and laboratory techniques. So, when you get to the lab, you have your microscope, you prepare a urine sample, can have it in the container, or you can just prepare a sample in a slide. What you need to see are microscopic, macroscopic, and chemical elements of the urine, which of course we know the standard urine what's supposed to be in terms of color, that is in terms of appearance, and in terms of the quantification, such as microbial, like fungi, if you see a spore, if you see if you see things to do with the flagellum, tail, if you see the yeast cells, we have fungal infection. So that is what we get to rule out some probable conditions and then have a definitive diagnosis. Now, renal biopsies and scanner. Renal biopsies is just a procedure that involves taking small sample of tissue from the kidney for laboratory analysis. When we talk about biopsy, we take sample, we take body parts, we take pieces of the tissues of a living organism. But when you talk about autopsy, is pieces of tissues excised and taken off from dead organism, can be dead body of human body, dead cow, dead anything. That is autopsy. But for biopsy, a living. So the biopsy is taken either to diagnose suspect kidney problem, especially cancer, okay, or tumor, determine the severity of kidney disease, monitor treatment for kidney disease. So there are two different ways to perform a renal biopsy. The most common type of renal biopsy is called the percutaneous biopsy. Yeah, people who are presenting more of, cancer diseases, presenting with symptoms related to tumors. When we are doing biopsy, you really need to know the common one is percutaneous biopsies, or they can also use renal needle biopsies. So this one will use the FNAC, fine needle aspiration cytology. And an ultrasound or computed tomography, that is a CT scan, can be used to direct the needle. So when the needle is inserted inside the kidney, there must be a guideline. So you'll be visualizing it using ultrasound and you're inserting the needle. And then we can also talk about the open biopsy or surgical biopsy. This allows the physician to look at the kidneys and determine from which area the tissue sample should be taken. Now, renal function test. Renal function test is something great, and you should know about renal function test because most of the time we don't need to do specific thing. We don't need to do urinalysis. We don't need to do the urography, intravenous urography, the cystogram. So what we do, because we know the normal level of creatinine in the blood, we know creatinine clearance rate, and we know creatinine in urine. We know BUN, that is the burn. So things to do with the burn, that is blood urea nitrogen concentration in the blood. So blood urea nitrogen concentration. So if they are below or above the normal ranges, we know there's something wrong with the kidney. So they can be specifically pointing to a condition. So you have to mastermind the normal ranges, you have to know, and then you have to know which condition will be prevailing if we talk about, elevated creatinine. So mostly we know the normal range, and if it is elevated by either 50%, you know very well that here is where we are going. So if we have poor creatinine clearance, we know there's something to do with the kidney glomerular filtration rate, which can be secondary to a primary cause. And that primary cause can be something also which is condition in the urine, in the kidney. So that is that. So conditions, let's check on the conditions affecting the renal system. Mostly is pyelonephritis, renal failure, and those are the things that we are going to check. So talk about pyelonephritis, can either be acute or chronic. Similarly, renal failure can also be acute or chronic. So what is pyelonephritis? Just inflammation of nephron, okay? Everything ending with ITS, I told you in pathology, it means the inflammation. So when urinary tract infection progresses to involve the upper urinary system, a potential serious infection can cause severe septicemia. That is, blood, infection on the blood. So like bacteria in the blood. Septicemia is a terrible infection, or the blood is contaminated with infection microbiome. So almost always curable with antibiotic, but sometimes very hard. It depends with which. Like we have this very common causative agent, a bacteria by the name E. coli, Escherichia coli. It's common. It's commonly associated with UTI. Okay, so it can, because the pyelonephritis can be caused by bacteria or virus. Okay, and I've told you just inflammation of the nephron. So the bacteria can be carried to the kidney through the bloodstream, and also can ascend from the urethra and the bladder. So it can come from the urethra and the bladder, or it can come from the blood directly. Okay. So those are trace, those with bladder infection, those with anatomical problems or the UTI, people with enlarged prostate, people with renal stones, people with vesicourethral reflux, okay, VUR. So women with short urethra, many sex partners. And the symptoms, like every day, if you have infection, first thing, fever, 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 fever. Fever, is because of the, inflammatory mediators, which always, because if you have a condition, inflammation sets in to try to remedies. We have mediators such as cytokines, the bradykinins, the leukotrienes. They play very high role in terms of bringing in fever. Okay, and so in infection, you'll get to see fever, backside and groin pain. Get the groin pain, the pain at the groin region. Okay, and the lower back pain also. Nausea and vomiting comes in, cheese and frequent painful nausea and vomiting is always almost most of the systemic conditions, because your nausea and vomiting, the chemotrigazone, the chemoreceptor trigazone, which is responsible for emetic behavior or emesis, is connected to the nervous system, which actually is denervating the entire body. So we have chills, frequent painful urination, and increased urgency. Those are also indication for pyelonephritis. And complication can come, especially if these conditions are not treated. We can have permanent renal scars. We can have hypertension, renal failure, congestive cardiac failure is not in the list, but it has to be there. It is there. So when you want to diagnose, or when you are diagnosing, when diagnosing this patient. We can carry urinalysis. I told you how it's being done. We can do urine culture. We take a sample of urine, we put it in a medium culture, and then we culture it to see which bacteria will breed. We can do ultrasound. Ultrasound will rule out abdominal masses, which can be directly from the kidney. Okay. Yeah, we can do CT scan. Will give us a detailed, illumination and expression of the kidney in terms of the 3D image. We can do DRE, we can do voiding cystourethrogram, okay? And management mostly recommended are antibiotics. We have nitrofurantoin being used. Some people use Septrin, that is cotrimoxazole, okay? Sometimes if it is very hefty, some people can use, yeah, there are many drugs, okay? Yeah, clindamycin can be used, right? So there are many. Ciprofloxacin can be used. Bed rest can be recommended. Repeat urine culture, hydration, unampea maji mingi, supposed to take a lot of water. And then we do monitor input and output for chronic pyelonephritis because we know if the output is reduced, there is something, there is a problem. There's a level if there's a level if you're classifying the renal failure in terms of glomerular filtration rate, you realize what ranges will give us what percentage or what level of kidney failure we having. Monitor vital sign as usual for our nurse. Renal failure. This one now occur when the kidney cannot remove the body's waste or perform their regulatory function. And the systemic diseases and final common pathway for many different kidneys, UTIs. So normally there is an increase in the number of deaths from renal failure each year. So out of many other killing conditions, kidney or renal failure comes in also at the topmost position. So when you talk about acute renal failure, is acute, it's sudden, and the patient goes, it's a rapid loss of renal function due to renal damage. And the treatment is aimed at replacing renal function, either temporarily, which reduce potential cost of increased renal injury with the goal of minimizing long-term loss of renal function. So an accepted criteria for diagnosis of acute renal failure is 50% increase in serum creatinine above normal, whereby normal is should not be normal is less than 1 milligram per deciliter. So yeah, so the urine volume may be normal, of course, sometimes, but now creatinine level will be used. So when you talk about the urine volume, oliguria, when I say oliguria, it means that you're producing less than 500 mils in 24 hours. Anuria, less than 50 mils. Non-oliguria or oliguna, normal vol but high blood waste. So usually there is a specific underlying problem and some factors may be reversible if identified earlier. So treatment promptly and hypovolemia, hypertension, reduced cardiac output, heart failure, check on that, obstruction of the kidneys or lower urinary tract, tumor, blood clot disease, bilateral obstruction of renal vessels will result to kidney failure. So all these conditions mentioned here can cause renal failure. Okay. So types of renal failures, they're classified into three: prerenal, intrarenal, and postrenal. So prerenal is before the blood enters the kidney. So anything that happens that can make the kidney to fail based on the blood circulation from the heart to the kidney is under prerenal. Intrarenal is within the kidney itself. So anything that the kidney to get damaged within itself, like acute tubular necrosis, is under intrarenal. Then postrenal after kidney, that is toward the ureter and the bladder. So any obstruction the renal flow off from the kidney, that is the pressure increase due to backflow and decrease GFR, all those ones. So on postrenal, we can talk about acute tubular necrosis, which is characterized by intratubular obstruction, tubular backleak, vasoconstriction, changes of glomerular permeability. So all these one will cause decrease in glomerular filtration rate, that is the output of urine, progressive azotemia. Azotemia is increase in nitrogen in the blood, which is dangerous, fluid and electrolytes imbalance. Progressive nitrogen will also cause progressive increase in the urea. Then you'll have azotemia. So fluid and electrolytes imbalance come in. So we'll get to learn more from here, specific causes of ARF and all that one in the next session. So what we've covered today will compound your exams for today. You can always subscribe and follow in the YouTube to get the updates, or you can check to get where you can find the video class so that you can join when I'm presenting.